Centene team over several months, basically building the architecture structure and working towards kind of the technical solutions that we need to have in place to support that interoperability. And really from our standpoint, those weekly meetings set the deliverables, provided us with the timeline, and really following through with kind of at the end game and engaging and understanding the Da Vinci implementation guides, which my technical team hadn't been involved with prior to our engagement with Centene, and InterSystems sponsorship and involvement has helped get that from concept to real implementable technology, and we really were able to deploy in our development environment a real-time working interoperable solution. So.
Thanks, Michael. And from a Centene perspective, speaking about the partnership with UC Davis, Michael and team has been, collaborating on multiple different projects, before this. So we had a very good partnership and relationship with other projects. ADT was a good example where we built out a lot of the competency using HL7, and then we actually did a lot of work on other solutions with them. So this was a natural progression with the partnership we had, and with UC Davis and our advanced technologies that a couple team members on here, Howard and Saul, who led a lot of the implementation in terms of identifying the FHIR artifacts required, working through the implementation guides, working with the team at the InterSystems and with UC Davis on the project planning and the implementation to get this POC completed. So it was a great partnership with Lynda and team and Michael and team, but it was an exciting opportunity to learn about the future of how we're going to do prior authorizations and participate in this pilot.
Great, thanks. So why don't we move on to the next slide? We can talk a little bit about how we structured. So, from the perspective of the whole team, we did set up some goals, right? Like we collectively said we wanted to have an infrastructure, we wanted to be conformant with the IGs. And by the way, there was a lot of conversation back and forth about what did that mean? What did the IG have in it? But I want folks to understand, and we have a lot of technical folks joining us today, that at first it was sort of we're all going through to try to understand it, but once you start getting into it, it's doable. It's something that we think is pretty easy to sort of get and adopt once you've started the process. And so we wanted to make sure that we could engage Epic and use that as part of the workflow, and you'll see that in a bit. And also integrate, Centene was working with Smile CDR and their systems again, because I think one of the things that we were trying to do is to get rid of the barriers around using a process that was manual, right? How do you build something into workflow? And so, Michael, you might want to talk about what that looked like on your side, and then on Centene, Mahesh, talk about that, because that's a really important thing. I think one of the beauties of the IGs is the fact that it tries to build things into your workflow.
Yes, and that's actually part of the overall strategy, is that, part of what we want to do is make essentially frictionless connections and with our partners, our payers, our community providers, and our patients. And so, of those four pillars, this aligns with what we're doing from a payer perspective, and really trying to implement the technology that allows a user of our EHR system in frame and in workflow to be able to make that request real time. Again, eliminating a significant amount of administrative burden and follow-up and manual processes that really, and again, the slides will kind of walk us through this, but in workflow, they'll actually enable that referral coordinator to submit the referral request and get in real time a response based on the rules on the payer side or the Centene side in this instance, and get that information back and be able to respond and get that authorization as part of a single workflow, as opposed to a disjointed, some manual, some interoperability, some paper, maybe even a phone call or two. I think we've all dealt with that, or maybe even a fax. I know Mickey might hit me if I say the word fax, but anyway, that's really for us. That's what we're trying to do, and that's part of the reason that we're creating this framework, because now that we've implemented with Centene, we're hoping that any of the other payers who are ready to connect we can partner with them and move that forward so that it's a united workflow, and I did use united on purpose, but a singular workflow in the EHR, regardless of payer, for those referral coordinators to request that authorization and then get that response and really work through that in a consistent manner across all payers.
And from Centene's perspective, I think this was a great opportunity first to build a foundation for some of the FHIR infrastructure that it is this implementation guide is leveraging, and also this prior authorization use case. There's quite a bit of opportunity to optimize the workflow, improve decision-making process, and integration with the provider system. So it was a great opportunity to move forward in terms of building our foundational infrastructure, right, to support some of the upcoming regulations, some of these, proposed rules in the prior authorization space. So it was a great opportunity to learn about, the Vinci, the implementation guide, and then also, building on the foundation of what we did with some of the CMS ONC interoperation regulations to continue the work so that we can be ready for, any upcoming regulations. There's a lot of, discussions about upcoming regulations using this guide. So that was our intention, is to build a foundation and get ready for some of the work. So.
Great. Next slide, please. So, Michael, why don't you talk about this? Because I think this was, you and Centene really laid the foundation for this goal.
Yeah, I mean, I think I touched on it a little bit earlier. From when you think about the customer, obviously the patient is a customer of both Centene, HealthNet, and UC Davis. From an experience improvement standpoint, if you look at just the average days to authorization and scheduling a visit, especially with specialists, and the limited schedule that may be available, time is of the essence, especially depending on the condition and the reason for referral. So from a patient as customer experience, that is key to expediting the scheduling visit, expediting the clinical care, and that seamless integration allows for that to happen in a much more expedited way, especially as we build out some of the rule sets and some of the automation on the backside to ensure that any of the documentation that's required for the authorization is also part of the FHIR connections that we have between the organizations, as well as being able to automate as much as possible. So we don't even need the referral coordinator to be there to trigger the transaction as the referral or as the order is placed for that specialist visit. That gets sent out, the information comes back, and then the scheduling, it shows up in the scheduling work queue to get that patient in-house. From a IT play, so the internal systems and users and the administrative burden, you can think of it again as we're allowing the technology to do the work, to automate as much as possible, and to provide an opportunity for things to happen in a more expedited way, as opposed to, again, with the faxes and the phone calls. So we've got lots of different customers at play here, but I think that the experience is improved. The more we can provide self-service or automation, the better it is, and I think the happier and more expedited care, as always, makes people feel better, and it's the right experience. So that's what we're working towards.
Yeah, and from Centene's perspective, I think our major goal was to reduce the time it takes to process prior authorizations, and give solid requirements to our provider partners upfront to say, hey, does this require this authorization? Is this required for this service? What documentation is required? And then be able to process that prior authorization and provide status visibility in a real time. So that's our business goals to improve that workflow and the visibility of those prior authorization as they're getting processed.
And if I could add a note about InterSystems in that regard, one of our goals, we've worked with UC Davis for a number of years to build out infrastructure for integration and interoperability and to integrate with Epic, providing specialized data such as genomics and making use of single sign-on and other technologies, smart on FHIR, in order to do that kind of integration. As acting as a broker in this particular instance with that InterSystems software, we're able to build something that is very scalable for extending additional payers in order to participate with the prior authorization, but also to add other additional use cases and be able to make use of all the FHIR infrastructure that they have in order to do additional use cases in the future. So we're looking at something that's very scalable and extensible, a foundation that they can build on.
Great, next slide. All right, so let's talk about how do we define success? And I think we're still in the process of defining success, but why don't we start with Mahesh and then Michael, and then we can talk about our goals at InterSystems.
So from Centene perspective, success here is around, the prior authorization process, reduce the number of denials, right? Fewer denials issued, as we have prior authorizations coming that are required, we actually have a clear understanding of, what the documentation is required and the questions that needs to be asked up front. And then this helps into quicker, review process and approvals. And then it also reducing a lot of the back and forth that typically happens with prior authorizations when authorization requests come in. There's an RFAI that is sent out for requesting for additional information. And then typically information is exchanged back and forth, there's Q&A, and then there's an approval. So, the goal of this pilot, this implementation guide from Vinci helps us reduce, number one is, do you really require an authorization? What type of documents do you require? And then kind of, getting all the information you need for the authorization to be reviewed in electronic fashion so you can get a response back to the provider systems, in a timely manner. So that's been success metrics is, reducing the number of denials, reducing the number of, no prior authorizations required, reducing the number of RFAI requests we send back and forth with our provider systems.
And again,
Michael, over to you.
I talked about it a little bit earlier, but part of the success measures is that you actually have to measure things. So today, when we get a fax in, and then somebody might manually key it in a couple days later, and then the referral gets the authorization request gets sent to Centene, and then they've got to process that request depending on how it's received. Being able to measure all those manual processes in any meaningful way is difficult, and I think that the automation allows for us to be able to actually measure when did we get a request, when did we send a request for authorization, when did we receive a approval. Obviously, all the automation improves the ability for us to respond immediately to requests, especially given the interoperability that we put into place, whether that be via a user and workflow or via the automation we put in place. So again, by having this in an interoperable framework, it allows us to measure exactly when things are happening, how many things are happening, what the process is, and the speed, so the quicker turnaround time, again, from the receipt or the request to the actual scheduling of the visit and the clinical outcomes that come with improved in speed. And then again, reallocating resources from doing manual processes to again, putting their energy into more high-level tasks as opposed to, again, just placing requests, making phone calls, checking websites, submitting forms. I think, we're not doing any time motion studies here at UC Davis, but I think we all understand the idea that the less time that somebody spends at a keyboard or on a phone or looking at a website or sending faxes, and doing, again, higher level tasks, the more meaningful work that's being done, and that takes some of that, again, that administrative burden and cost off of our organization for better care.
Now, Kevin talked about some of our success metrics, but one of the things I tell people when I try to describe what is a Da Vinci implementation guide, and from our perspective, it's kind of like a recipe, right? So here's the recipe and you have the ingredients, and you have to have all the ingredients. And as a vendor, one of the things we want to make sure is, do we have all the sort of ingredients we need to actually make it work? And so for us, one of the seminal ingredients for this particular use case was, being able to implement CDS hooks, to be able to move the data, back and forth and answer the questions that were being asked back and forth between the payer and provider. And when we get to the next slide, they're going to talk more about the technical side of this, sort of what was involved technically, but that was a real goal. And then you've got all the, the great cooks that take those ingredients and follow the recipe. And, hopefully when you get to the end, you've sort of, finished and made what you intended to do. But like any recipe, it's not going to be exactly the same every time, because guess what? No two sort of implementers are going to be exactly the same. And so we like to think of it as, how do we make sure that we can, make it easy for those variations that we're seeing either on the payer or the provider side. And in this case, Kevin just talked about working with, integrating with Epic and making sure that that workflow worked seamlessly as we, push the data through from Epic through our platform and then over to the Centene side. So I think that we also see that, burden reduction hopefully will be coming out as a set of regs soon, and prior auth is part of that. So we were anticipating that, and we want to make sure that what we do with our technology can support both payer and provider side of prior authorization. So Alex, if you go to the next slide, at this point, I think the team's going to talk a little more, get in the weeds, and talk about some of the technical considerations and implementations. And I'm hoping somebody from the Centene team can also talk about the CMS exception to the X12 transactions.
So from a UC Davis side, again, following the implementation guides and leveraging the support and expertise of InterSystems, we've been able to essentially connect into Epic and deploy in the workflows where the referral is requested, ensure that transaction gets delivered through the FHIR APIs, and depending on which transaction we're talking about, FHIR to X12 or X12 to FHIR, some of that transitions being made in the middleware platform today. Part of the move forward is really to be just a FHIR native transaction. And for us, it really just embeds that workflow, the workflow for the referral coordinator when they're requesting the authorization, embedded in workflow. And again, we'll have slides to kind of to walk you through that workflow and what it actually looks like for an end user. But from a technology stack standpoint, is leveraging the transactions out of Epic, leveraging the hooks that we put into place that connect through our middleware, and disintermediate the Epic platform from the messaging and connectivity platform. Again, from a security standpoint, a lot of what we try to do is separate out, especially out of network connections, from directly interacting with our EHR directly, and manage that through the InterSystems platform, and then pass those connections, the outbound connections, off. And then obviously they're all bi-directional, so the response is back. And again, the workflow you'll see in the upcoming slides will give you a clear example of what an end user might experience as part of this process. Mahesh?
Yeah, from Centene perspective, Howard, so I'll jump in here, but I believe we actually bypassed the X12 to 78. We had a Vinci exception in place, or we took advantage of the exception to go directly from the FHIR request to FHIR request processing on our side. And the X12 278 is something that we bypassed. And I think that's one of the things we're proposing as part of that, regulatory guide, proposals, is to say, we should have paths for both of these paths, right? If there's opportunity to work directly FHIR to FHIR on the provider and payer side, that's what we should pursue. And if there's a requirement, if there is a need for 278 processing, I think that should also be there and supported in the platform. But to speak to our Centene side, our team chose to use the exception in place and process the FHIR request directly in our platform.
Yes, and Michael made several references to the. Oh, excuse me. Go ahead.
Go ahead.
I was just going to say that Michael referred to the workflow several times, and one of the things that's so important deploying some new technology is to think about how that is integrated into the workflow within the organization. And the IGs that describe this use case designed it in such a way that the clinician might make that prior authorization request at the time that an order was being placed. But in UC Davis's situation, it seemed better to integrate that into the referral management team, so that where they are managing those different referrals of different types, some of which now can be done automatically with this technology, others are not. And that made it an easier deployment into the organization with the workflow that they have with minimal disruption for the clinicians. And so each of these implementation guides has an amount of flexibility in how you can actually apply that within your organization in a way that makes best sense. And so I think that combined with making the exception that was done to eliminate the transfer through the X12, 278, and 275 in between, and some other optimizations that we talked about as we've gone through that and learned from our experience, I think has tuned the whole process to really improve it and set the stage for the kinds of things that might be done next. So, next slide. So these are some links, of course, that we use as the basis for a lot of the work that was done. So those are the good things to take a look at to dive deeper into some of the implementation guides and background.
All right, next slide. So I think that the team's going to then walk folks through the workflow of our pilot. So we set up, I think it was 6 sort of scenarios that we're going to test. And I love this part. It took us probably 6 months to sort of get through the governance and to line up resources and to understand the IGs and to get all the teams sort of, lined up where we needed to go. But January 1st of this year, when we said go, the work itself happened really quickly. And so what you're going to see and what they'll talk through as we go through this workflow is one of those scenarios. And, Michael, I don't know if it's your team or Centene's team or both that's going to go through this, but it'd be great, to describe this pilot we did, because it was a great concept.
Yeah, so why don't we go to the next slide, and then I'll walk through the kind of the overview, one more slide, sorry, of really kind of what we ended up doing and where we built pieces. So as you can see here on this slide, really the transaction, where particular pieces of the transactions are getting created, transformed, and communicated out from the UC Davis systems and network to Centene. And again, part of this, as I said earlier, is that we're building our connections to the outside world, outside of our firewall, especially with our FHIR endpoints, outside of the Epic infrastructure, especially for these types of connections, to ensure the right security is in place and that we're protecting our PHI and our EHR environment from bad actors. But part of that partnership with InterSystems is to deploy the right technology in the right places, making sure it's secure and delivers the right capabilities in the right places. And what it does is it allows Epic and the EHR to really focus on what it does really well and managing those workflows. And obviously it's a system of record, so it's going to have a key role in these transactions in delivering the data that's necessary or receiving the data that's necessary, leveraging the transactions we talked about, the CDS hooks, the query language and essentially any of the authorization data that comes back, and again, delivering that within the framework of the EHR. So no, why don't we just go to the next slide, and I'll hand it off to Mahesh kind of once we get through, because I think we've got some slides on the EHR workflow at this point. So next slide. Yeah, one more. So essentially what we're doing here is walking you through the referral coordinator's workflow within our EHR. So what you're seeing here is they're requesting, and for whatever reason, they decided to test Botox. So to remove all the wrinkles in my forehead here, where I'm going to get a Botox procedure, I'm Mina, excess test FHIR. So if anybody's concerned about PHI being displayed in our demo system here. So essentially what we're doing is we're just walking through the workflow within the EHR to deliver the transaction that we're going to need to get across to Centene to get authorized. So this tells you the status of pending review. Essentially the system automatically sets that to pending review. It's a priority of routine. Again, some business logic behind that gives the referral coordinator an opportunity. If there is an urgent need, they can set the priority. And if you go to the next slide, it'll take you to the next step in the process. So from that standpoint, the order is placed. They provide the information that they're looking for authorization for. So, I'm not a clinician, but that 64612 is the procedure code. And that gets bundled up and put into the transaction that we sent across. Next slide. And essentially, again, what we're trying to do is give them the control. So if they're ready to go ahead and send that transaction today, there'll be a button that we're going to hit to generate now and send that across. And so this way, the referral coordinator can send that notification to Centene to ask for the authorization. Next slide. So the Smart on FHIR application launch and CDS hook call. So next slide. Again, it will walk you through kind of the next steps in the process. So part of one of the things with traditional interoperability is sometimes we push a button in a system and the person that executes that command has no idea whether that transaction was sent or not sent or what's going on. So there's a visual representation here is that we've sent the transaction off to Centene to do that prior authorization. Next slide. And now it tells us, okay, we've got that queued up and it's ready to go. It's in draft, and you can see a prior authorization that had been approved through this process. So again, we know that transaction's queued up and off to Centene. Next slide. Did we go one slide or two slides? Okay. So the referral status is now draft. So everything's packaged up and ready to go. And then you essentially click on your determine prior authorization status, and that sends that request off to Centene. Next slide. So now what's happened is that request has been sent off, and there's a questionnaire. So essentially the referral coordinator has requested the authorization. Centene has responded and said, oh, to authorize this request, we need you to provide some additional information. In this particular use case, it's a questionnaire. So if you go to the next slide, this will actually talk about that response. So one more. So I'm going to turn that over to Mahesh, and he can talk about the Centene side of this equation.
Right, and I'm going to be Mahesh for a little bit. So thank you, Mike. So as we got that communication coming from UC Davis and InterSystems, that's going to hit our clinical data repository. We use Smile CDR for that. This is just representation that it would have to authenticate. Clearly, nobody has to put in their user ID and password. So at that point, we get to authentication. And the next slide, please. Of course, we're protecting all the PHI. Took a while to get firewalls configured and all of that. So this essentially is some of the permissions that's needed within our Smile CDR instance. With that, we're going to, read the information. There's certain patient information, and essentially
behind the scenes, this is authorizing access to our clinical data repository. Next slide. So now that we get that communication and there's a questionnaire, this is a Smart on FHIR app, essentially, that's initiated. These particular questions come up for the review specialist or authorization specialist to answer. Depending upon the answers here, we could also have our clinical decision support system take these in, make certain determinations. We could chain to other questions that are conditional. But once we did a fairly simple Q&A here, and then based upon the answers to the questions, we would either approve or deny, or ask for additional questions. So in this case, the user would hit the submit button on the Smart on FHIR app. And next slide, please. And at that point, really, we're initiating the prior authorization PAS implementation guide. All the data that's associated with that implementation traverses the two organizations, actually three. And then at this point, we can pass back an approved status. That gets logged, of course, in our system because we've gotten all the critical data elements in the FHIR transaction bundles that we need in order to interface through SMILE CDR to our authorization system. And then this comes back to through InterSystems to UC Davis. We present them with an authorization number, which is cross-referenced on our system, as well as the UC Davis auth number. And then at this point, we've got a completion of a round trip with questions for an authorization. Michael?
Yeah, thanks, Howard. So what you're seeing is now we're back in our EHR. You can see that the patient's referral status now is moved to approve with an authorization number within the EHR that can be leveraged for the claims admin and filed appropriately in our EHR to submit with any of those claims. So what we're now seeing here is that through this round trip, in one workflow, one integrated workflow, we've been able to pass that transaction across to Centene. Again, part of this is part of the pilot is you saw the pop-up for the login and password. I think as we move forward, more of that automation will be in place. We'll have more Smart on FHIR connections, and maybe even some of that questionnaire data can be answered as part of the exchange that we're going to do when we do these auth requests. So now that we're back in Epic and we've got that the referral authorized, we're ready to go. So you hit the next slide. And as you can see, again, depending on where you are looking within the EHR and the patient's chart, you'll see this particular procedure has now been authorized as a covered benefit, and the transaction is complete. So no more follow-up, no faxes, no phone calls to check the status. And at this point, with the authorization and the covered benefit, we can move forward with scheduling Nina for her Botox appointment.
Great, thanks.
So that's the end of our workflow. Back to Lynda.
Yeah, next slide, please. So I think one of the things I would like one of you to speak to, and maybe it's Howard, is how you take some of your clinical guideline rules. So for example, this was Botox for migraine headaches, and how do you translate that into CDS hooks? Because I think that's an important concept that payers need to understand, is that you've got clinical guideline rules, you've got things that you're using a vendor to do that, or you've got your own homegrown ones that need to be translated so that it can answer the basically question that's being asked of it from the provider side.
All right. So, for this Can you see me? Yeah, there you go. For this particular use case, we proved the technology, but within Centene, we do have a number of clinical decision support systems. We use Interqual for a number of our web property and digital clinical decision support. There are other tools that are also exist within Centene. As we would build this out, we would leverage some of that clinical decision support. We have APIs to that we use in some of our other web properties. So that's one way of leveraging that capability we have today.
Great, thanks. And I think, the last thing we wanted to cover before we open up to Q&A is just have the teams talk about, so what does it mean to move to production? Because we sort of closed out the pilot work, and in some cases it was a transition to different set of resources, different teams to sort of say, okay, how do we take this work and move it to production? So we want to just talk a little bit about that because that's an in-process thing, and then we'll open up the floor to Q&A.
Sure. This is Margaret Kovach. I'm an IT director at Centene for interoperability. And our team is kind of picking up the mantle from Saul and Howard and what they did. And we are in initial stages to see where we want to host this, what does this look like, and going through basically what the future of this would be. Not to say that Saul and Howard are still heavily involved, and we did a lot of knowledge transfer sessions with them, but the future state is that we are researching it currently.
Great, thanks. So I guess at this point, go ahead.
Lynda,
Sorry.
just to make a comment. So from the UC Davis standpoint, one of the things is, and if you think about, again, the referral coordinators, depending on how your organization splits up the workload, you may be assigned one payer, multiple payers. You may have 7 different workflows to get your referrals authorized correctly. So part of one of our hopes is that we normalize this interoperability so that all of the payers are working through the integrated network by supporting these transactions so that they all have the same workflow. Because now for Centene, as we move forward, we'll have a separate workflow and work queue for this automation, and then for the other payers that are on different processes, which is some of what we support today. Everybody has a little bit of different flavor of vanilla. It's kind of the same, but it's a little bit different. Really working to standardize those workflows in our implementation and create a singular way to get authorizations from the payer community, as opposed to 20 different ways to get authorizations. And I think, at least from our standpoint, that's what we're hoping this move forward does for us as well.
Well, thank you for those comments, Lynda. I would invite everyone to come back for the Q&A if you so choose. I have a variety of questions that have come in from the audience, and I want to pick up with one in particular. So, Michael, I'm going to ask you to talk about this is a question that I think came in around your slide 25. And there was a question, so folks don't get dizzy while I back up. Leslie's put the chat box instructions or the comments. Okay, so when you're back here on success metrics, if you're using APIs, then they should be the same. That's the kind of point. Are you talking about differences in how the data maps to FHIR resources?
So that was kind of my comment at the end, is that today we have a different process for each payer. In the future, what I'm hoping is that transaction standards are supported in the same way so that we can use the same workflow. So when you talk about a particular slide, I'm not sure which one you're actually we're referencing, slide 25, but is it for this diagram or is it something else? Alex, I don't know.
No, it was, and I felt like you addressed the answer, and then I moved on because I thought the schematic may actually help us.
Yeah, so, no worries. So yeah, so just like in V2 integration, an ADT is an ADT, but there are some local variations. And I think that, we can manage those, but as we look at the different processes from a transaction standpoint, the Da Vinci implementation guide is pretty straightforward for us as to know what transactions we're going to be sending to the payers and what we should be seeing back. So we're looking forward to that implementation, actually, as other payers are ready to do that.
So a couple other things that are kind of related to this slide and some questions that we've gotten relate to the process flows. So first one I want to tackle is, does Epic support your CDS hooks for your use case?
Yeah, I mean, CDS hooks is a part of our standard deployment. So yes, they're the Epic CDS hooks.
All right, thank you for that. And sorry, my screen keeps jumping on me. So the next question I want to ask you guys to talk about is the process when something isn't the happy path. So folks are really interested in understanding what does a denied prior authorization look like?
Well,
I can jump in from.
Go ahead, Mahesh.
From a Centene perspective, right? A denied authorization has a process for appeal, so that follows the general appeal process. But I think it's a question more in terms of, I think, what are we doing to minimize the number of denials? Maybe that's probably the question. So there's a couple things here that are helpful. In the current process, typically we get a request for authorization that is processed, and then there's a lot of back and forth, right? So what this proposed regulation has two additional steps. You see the coverage requirements discovery and the document templates and coverage rules. These are currently non-existent, but coverage requirements discovery actually helps you evaluate if this particular service requires an authorization or not. And then the second step here, document templates and rules and coverage rules, actually helps you evaluate to say, hey, what documentation do you require to be able to get this authorization required time, approved timely. So I think those two additional steps will really help reduce the number of denials, because there's multiple reasons why a denial could happen, right? One is because they don't have the right information, they don't have the right information in a timely fashion, or maybe the benefit is not covered, right? So by incorporating those two additional steps in the process, it's making it easier for the provider and the payer to communicate, easily, electronically, so they can reduce those denials. So, Michael, I'll turn it over to you to add from your perspective what your thoughts are.
Yeah, I mean, again, if we can move from a manual process to authorizing within workflow, and if you remember the screens, essentially, when we send the transaction, if the referral was rejected, then the status would say rejected and approved, and then there would be another process for our organization to work that, whether it's filling out a separate questionnaire, submitting additional documentation. My hope is that we get to a point where, unless it's something that's not covered, it's a non-covered benefit, which would be a status that would come back and say denied as non-covered benefit, we would get the opportunity to respond in electronically with more information if it was necessary. If it was denied for some other reason, then we can respond leveraging the same interoperability. Or, again, worst case scenario is it dumps out to a work queue, and then we do whatever the manual process is that we have. But the idea would be is that we move from 100% manual to working, a less percentage of denials manually. Again, these are all hopeful commentary. But as part of just what we've done so far, most of it is just the proof of concept is, can we embed the logic and the interoperability within the EHR so that we can submit a transaction to a payer partner, get a response, and authorize that referral request or that authorization request in frame, in the system, in a singular workflow. And part of the proof of concept is that we can. And so now as we move to kind of the next phases of this project, talk about operationalization, which is always hard for me to say, those things will work through policy and procedure around how those denials will happen and really what sorts of patients. We may just start out with a frame where we're only doing this with our managed care population. It might not be for some of the other patients that are covered by the Centene/HealthNet insurance portfolio. So part of our collaboration moving forward is to target specific populations, obviously depending on the plan. Every health insurance company has multiple plans with multiple coverages. and multiple different requirements that we're all trying to match up against, and that adds to the complexity. So when you talk about the denials, we're hoping to have less, and we're hoping to have that process for appeal be less complex than it is today, and that's really the general move forward until we can make everything perfect, right?
Well, and it is a journey, and it's a never-ending journey to being able to help people function at their highest capacity and let automation and technology really help us along the way. But until we get there, we still need to have people involved in the process, and they'll never be fully removed from the process. But we did have a question to better understand who's answering those questionnaires. Is it referral management staff, nurses, clericals? More complex questionnaires tend to require clinicians to get involved. And so looking to when you have this workflow, how are you engaging the humans when you can't automate it currently?
Yeah, so from our side, is that the transaction is getting submitted normally by a referral coordinator. So we have different work queues, again, by payer, by plan, that get worked within our organization. And essentially, when those questionnaires come back, there'll be a policy or procedure in our organization around what levels of service are appropriate for the referral coordinator to respond to and what needs a higher level. And so part of just the build process for us will be to make that determination and do some routing of those referral questionnaires back to the appropriate pool. So it could be a referral manager, it could be a clinician. Part of one of the cool things about the telemedicine and a lot of the remote working is that we have some clinical staff that are actually being utilized for telemedicine visits. We may be able to pull them into some of the administrative visits, do chart reviews, and actually help respond to those questions, where today they might be in clinic and book 20 appointments a day as a PCP. We may be able to leverage those resources in other ways to help with this administrative process. So it's something that we're going to work through organizationally, but we have a lot of flexibility and a lot of options, and we'll look at all those as we move forward.
So we have some questions that are around the Smart on FHIR apps, and they're kind of a variety of questions out there. And I want to talk about that before I want to have a round robin with the group about the governance complexities that Lynda mentioned in one of her remarks. And so we'll get into those barriers getting to the next stage and how maybe your prior governance experiences can get us there. But for right now, let's talk about what is the Smart on FHIR app that runs in the EHR? Which EHR app stores is it registered in? And is it registered?
So the Centene app is the Smart on FHIR app. So the launch out and the connection for part of the Centene app is in the App Store. Part of the functions that we've deployed through the pilot are direct connects that are in the App Store. And that's part of what we're doing in developing directly with our payer partner, Centene, of building those connections directly.
Yeah, and actually it gets into one of the other.
You can see the app in the app development all the time.
Go ahead, say again.
I was just suggesting, since the Smart on FHIR app is really more on the Centene side, for Mahesh, he can speak to kind of what development's been done on their side with the Smart on FHIR app, or Howard.
Yeah, Howard, please jump in. But I think the Smart on FHIR is primarily to answer the question around requirement. What documents are required, answering questionnaires. So Smart on FHIR is a technology that is enabled for all of the EMRs, so that workflows can be enabled on demand. So some of those solutions could be built so that it could be deployed into the App Store and made available to the workflow, to what I think Michael was speaking to. So the implementation we have is around using that technology to be enabled when the question is asked on the workflow to say, hey, I have a prior authorization, is a prior auth required? And then to add more questions in that process, that particular Smart on FHIR app is actually still pulled up. So Howard, please jump in.
Yeah, you got it, Mahesh. We architected the Smart on FHIR app. It was, pretty simple, for the pilot. We built that in Azure. We put it in through Smile CDR. So it was fully functional. It can be extended with additional backend APIs once we collected the data. But it's a pretty basic implementation. But clearly, it worked.
There are a couple other technical questions about the IG, so let me get to those before I get into my governance and barrier related question. There was a question that asked about at this, do you check if the provider is considered in network or not for the patient and which step you're doing it in? So I didn't know if you guys wanted to maybe talk about a little bit of the coverage requirements, discovery activities. And where that activity happens. Maybe I already answered it for you.
Are you who are you asking it about?
I'm asking it generally to you or to Mahesh about to help our attendee understand where the check occurs for the coverage related to in or out of network and where that happens in the process.
Yeah, I mean, from our standpoint, it's, yeah, go ahead, Mahesh.
Oh, sorry, Michael. From our perspective, it happens, around the prior authorization support. That's when you require your authorization, right? So the coverage requirements, that the first step in the process is more at the procedure level. It actually says, hey, for this, procedure is not required. And then the second part is it tells you what documents are required, and then they actually submit the prior authorization, which actually has the member information, the plan information log. So at that point, at that point, we will determine if the member is eligible, the plan is eligible, and then we can, process the prior authorization. So hopefully that answers the question.
It does. So another question that we got is about an example. If they're requesting an authorization for a procedure, does the procedure need to be codified using a standard that the payer system understands? SNOMED, CPT, ICD-10, PCS.
Mm-hmm. Yeah.
So all of our existing requirements, standardized code sets, aren't changed simply because we have a new mechanism for exchanging the information, in other words.
Yeah, the same set of rules you have today in electronic acceptance of a prior auth with 278, those same CPT based requirements, they still apply.
So another question that we got about the way the data exchange works is regarding the payer data. And they asked, does any of the data from the payer's response in either CRD, DTR, or PAS land into the EHR, or are you maintaining that outside of the EHR?
The plan is to have that in the EHR as part of the process.
So you're consuming the data. Awesome. All right, so what I'd like to do is ask Lynda to also come back on screen with us if she's still available, or Kevin. And I'd like to have a little bit of a round robin to build on this concept of you said we kicked off, we spent 6 months kind of governance, and I hope I am paraphrasing this correctly, sort of 6 months to get all the ducks lined up for everybody to be in agreement across the organizations. And then once you got to January 1st and you had the agreement, the actual development work went very quickly, which makes sense considering we're using fast healthcare interoperability resources standard. But what I'd like to do is kind of unpack that a little bit to understand some of the things that did take a while and why you felt that you encountered that complexities, and so others may benefit from being able to orchestrate their internal pilots and projects more effectively. So Lynda, you want to kick us off with a little bit about the governance opportunity?
Yeah, I'll start. So first and foremost, you have to make sure you have the right people and the right resources from your team. And each of us had a team, and it's not just a team of one, right? So you go internally, you find the right resources, and sometimes it takes a while to sort of line those folks up. And, our team was very new to Vinci IG. So part of it was just ingesting and figuring out, what does this statement mean, right? And then there's the second complexity, which is, layer 2 technical, is you actually have to find endpoints and connect to each other, which isn't sort of, it's inherent, but it takes time to do that. And I know Kevin can talk about that, and Michael can talk about the fact that, it was a couple of weeks back and forth, just sort of linking up endpoints. But it's also a process by which, everybody else has competing priorities. So part of it was just unblocking some of those competing priorities. And I know Michael and Mahesh can talk about sort of on their sides, because I think it took a while just to do some unblocking to get everybody sort of teed up to say, all right, it's time to go.
Yeah, and I mean, as Lynda said, the priority piece is that part of what at least my responsibility is to make sure that we're moving in the right direction, that it aligns with the strategic goals and some of the initiatives internally. And really, when we get down to, we finished the architecture, we've got the right people in place, and it's okay, we need to do this specific development task. We need to write this particular test script. We have resources on our side to do that. But until we get to that point, and I think we've all been to that through that process, is a part of the discovery and vetting and really trying to kind of figure out exactly how we address some of these issues. We really had to go through lots of conversations and understand our architecture, how we were going to connect, how we were going to deal with, EDI versus FHIR, X12 versus FHIR. All of those things had to be kind of vetted prior to us moving forward, exactly how we were going to do some of those things and what pieces needed to be in place. And so part of that process just took a long time. Obviously, competing meetings, we had a regular meeting, but sometimes people couldn't attend, things of that nature. But once we got the architecture in place, we had decided on how we were going to do the messaging, what the security protocol was going to be. And I think we've all been through projects where connectivity sometimes is the longest pole in the tent. We don't have a discoverable FHIR endpoint that's out in the public that tells you exactly how to connect to it, right? So we had to work through those things through some of our security policies to ensure that the connection was, our technology was deployed correctly and outside of our firewall, our endpoint was there and discoverable. We could connect with the Centene pieces. So all those things had to really be part of spinning things up before we could actually get to the messaging, the actual transaction. So Howard?
Yeah, I just wanted to add to that. The team that worked on the Centene side from the technology perspective is part of the advanced technology team. It's frankly, it's outside of the core IT group that is burdened with a lot of other, production-oriented, large projects. So Centene has made a commitment to have an innovation team, and we have a significant amount of tooling and talent, cloud-based solutions that we leveraged in order to move this kind of proof of concept forward. We live by demos and proof of concepts, and this is a great opportunity for us to take on some innovation and make a difference for our future. A company's commitment to innovation with a team similar to ours does help address the priority issues that often large companies are hamstrung by for these kinds of projects.
One thing that people don't think about that I think was important in that is assembling the sample test patients and code sets and various things for the use cases that we were going to test in the first place, and making sure that those were representative of what real data would be like, but still not have real PHI in there, so that we could exercise a lot of these technologies and API calls back and forth. So it took us a while just to get that basic set identified and build out all that test data so that we could exercise all aspects of the initial implementation.
Right, because although we just showed you one use case, we built out, I think, 5 or 6. So for example, we built out a use case where when you said, does this need an authorization, the request came back and said no. So that's an important thing for, a referral manager or provider to know. So that was a test case. We didn't demo it here, but it was, there was subsequent use cases that we built on. We actually had to figure out what were those 5 or 6 different incremental steps that were going to kick the tires of each of the IGs.
So how are we going to move forward with this project? You guys have clearly invested a lot of time and energy. You've gotten leadership buy-in. You've done the demonstration, so to speak, the proof of concept. So let's talk about getting to the next stage of this. How do you plan to move forward, and what barriers do you think you're going to experience? Whether it's people, process, technology, compliance, obligations. Can you guys speak to your next steps and how to bring this value proposition more broadly to your community.
Yeah, I can jump in from Centene's perspective. I think, we're evaluating health plans that are looking to pilot with us, right? So this, with, UC Davis, of course, is a good partner. We're evaluating from a California perspective, is there health plan partners that we can partner with? And then we're also evaluating from a technology perspective to say, hey, where do we go from a pilot perspective that's been implemented to a production system, right, that we can support, right? So those are two major areas we're evaluating. And then this is, like we talked about in the introduction, right? A lot of this, our thought process is this is the foundation for some upcoming regulations. So it is required, it is going to be required sooner or later. So it is an investment that Centene is willing to make to evaluate, I think, how do we move forward beyond a pilot to get to a, place where we have a health plan that is willing to partner with us to move this forward to production, I think. So, Michael, turn it over to you.
Yeah, and from our perspective, so there's operational considerations. So again, the way that referrals are coordinated or authorization requests are handled today, there's a team, there's a work queue, there's a process. What we're doing now is implementing a new process that should be expediting the work, but it also is different. So now I have to work through the operational aspects of training staff on the new process. And again, there was a good question, is what happens when it's denied? What happens if it needs other documentation? What happens if it needs a higher level of review and response? We're hoping that when we build this at the end of the day, that any additional documentation that's necessary to authorize the request can be collected via the FHIR APIs from Centene based on our trusted relationship and the fact that they know who the patient is, and essentially we'll build a connection to the FHIR APIs that can give them access to the clinical notes they need to authorize. That's the end goal and hope. The questionnaire pieces, there's obviously going to be some things that where the data doesn't live specifically in EHR, it requires some higher level response or interpretation of information that might be there. But I think in general, the idea for us is we've got to engage on the operational side and not just the technology side of how will we implement this, what's the best use of the technology, how do we key in on maybe particular procedures that, again, are very routine, very easy. Take the top 10 procedures that, for the most part, require very limited additional data and put those into production and say, okay, we get, and I'm just going to use my use case, we get 1,000 Botox auth requests a month. If we can automate those requests through this process, that reduces the workload, again, allows folks to focus on higher level tasks or more complex tasks as we move more of these things into production. And I think part of our learning curve will be is just to find that sweet spot of what makes the most sense to do in an automated way, what is essentially too complex at this point that isn't supported by the interoperability, and we just push those off into a different work queue and have, as we bring more payers on to the FHIR interoperability and these use cases, moving again more of the things that can be automated into the automation as opposed to trying to put everything. And again, don't make perfect the enemy of good, right? If I can make 80% progress and automate 80% of my auth requests and have 20%, even if it's 20% per payer, it's not 100%, right? So, we really have to invest time and energy around understanding our mix of when do we need auths, what is the level of auths, what sorts of things can Centene and the other payers automatically authorize through our FHIR connections and through this interoperability versus things that are just too complex today or require a higher level or a different contract or those sorts of things. So those are all considerations as we move forward, but that'll be part of the planning process, is engaging our operations team, building a training plan, updating our policies and procedures, and then really targeting the high value, high automation possibility items and auth requests that we have in place.
Sounds like you've got your project plan ready to go, and it seems like you've also given consideration to incrementally tackling all of this, recognizing that you've got to make it work in the workflows, and you've got to also think about the burden on the provider, clinician, activities. And it sounds to me like that operational engagement is really critical, because they're going to have to be living with dual paths, or more than just dual paths at times. And are you experiencing, how are you tackling that with your operational partners, Michael?
I mean, the first thing is just engaging early. You know, part of engagement is communication. So, you know, when we started this technology pilot with Centene, you know, I engaged our director. You know, we have a team that handles referrals and auths through our patient contact center, because a lot of those things, you know, we get, not only do we have a lot of requests for payers to authorize visits, we have a lot of referrals that come in from community providers where we need to manage the authorization process there as well. So we have a fairly complex and highly sophisticated referrals team. And so the first thing is just engage and let them know what we're working on, let them know and ask them if they have other payer partners that would be interested in partnering with us to do these sorts of things. You know, we had a relationship with Centene, and we're able to move that forward based on kind of some side technology relationships, but really trying to move them along to the continuum to understand this is going to save you time. This is going to be a standard that we can implement across payers. And really, again, we're going to be able to automate. So hopefully, if we do this right, we'll be able to submit the auth request automatically, and they'll never know that it actually was auth, because now it's in a scheduling queue because the authorization has been received, right? So that referral team, I'll call it a frictionless engagement with the auth process, right? The referral request is submitted, it gets auto auth on the backside, the authorization goes in, and it drops into a scheduling queue, and it's not a change in their workflow because they requested the auth. For any of the other things, it'll follow the existing path as we kind of migrate through those high value things or high volume things that take more time. So I think that from my standpoint, it's talking to them early, ensuring that we understand process and policy and procedure, looking for partners that can take advantage of this automation, that are interested and ready in doing that. We've had a ready partner in Centene and are looking for others. And then making sure that as we transition each payer to this new process, we implement as much automation as possible, so that the change in their workflow isn't, well, I'm going to do this and then this part and then this part, versus I'm going to send it through the interface, or we're going to put it over here and work it manually, and kind of managing that and having good reporting, good communication is going to be key for us to be successful.
Tremendous remarks, and very thought-provoking for all of us as we move forward in bringing reduced burden and increased speed to services for our patients. Any final words before we wrap up for the day? Thank you so very much, presenters. Last parting words?
I just want to thank everybody for joining. I want to thank our partners who have been working, with us on this for a year, and we are looking forward to, moving it to production, where we can actually start doing some of that measurement that's built into that exception that CMS granted. So I think it's just, as we've all said, it's incremental, but it's important, and it will continue to move forward.
Well, thank you for being innovators, for leaning into national standards development work, and making it better for all of us as patients at one point or another in our lives. So with that, everyone have a fantastic day, and we look forward to seeing you at our next community roundtable, which it will be September 28th. We look forward to your feedback and appreciate your patience during our technical glitches today.